afternoon, everyone. I'm Chidinma, the Next Year's Health Analyst. You're welcome to today's session, Next Year's Universal Health Coverage Dialogue Series. The first topic we're going to be discussing today in this series of dialogue programs will be health insurance in Nigeria, progress, gaps, and challenges. But before we proceed, I would like to hand over to the moderator of today's event, Mr. Felix Obi, a health financing expert. He's the Senior Program Manager at Results for Development. This promises to be an educating session, so sit back, relax, and enjoy the ride. Thank you. Mr. Felix.
All right. Thank you, Chidinma, and welcome everyone in the hall. I think this is the first policy dialogue that Next Year Health will be hosted on Universal Health Coverage. And it's really my pleasure to welcome all of you. Like Shiki in the introduction, I work with Resource for Development, and this, like next year, our commitment is to ensure that Nigerians have access to universal health. And it's really commendable that next year is leading this discourse on universal health coverage, which will be taking time to unwrap today, especially from the perspective of insurance and other aspects of financing for health in Nigeria. And before I introduce the topic, late last year, I think it was around November, I and another colleague, we visited the chair of the Senate Committee on Health, and he was running frantically that day to do some things, and by the time I was curious, so I did ask him what they were working on, and he said they just passed, the NHIS bill, the revised bill, which was sent to the president, and the president rejected, he didn't sign. So it was sent back to the National Assembly. So they were doing some revisions and removed some provisions that the president has raised issues with. So it brings us to the point where we know that health insurance is something very critical for Nigeria. And it is really an important thing for us to discuss. And I want to welcome everyone, people online. We have so many people online, and we want to ensure that it is very participatory. We have opportunities for us, those online, to ask questions, make comments, and also those in the hall here. And without further ado, we want to now have the welcome note from Next Year Health. I want to call Patrick Okibo to unveil Next Year Health, or the representative of Next Year. So we have an array of panelists, very experienced resource people. I'll just do a quick introduction. At my far left is someone that we have worked together for over 10 years in this sector. And his name is Dr. Francis Ukwije. Maybe you can introduce yourself. He's the senior health economist with WHO Nigeria office.
All right, thank you very much. Thanks.
Okay. And then to his right is someone we call Madam UAC. And she is also a health economist. And if you may not realize that she's the head of the health financing and equity unit in the Ministry of Health. Make welcome Dr. Nneka Oji.
Thank you very much, everybody. Thank you.
All right. And then to my left is, I hope, Dr. Ephraim Okoye from, because he's from the Federal Medical Center, Jabi, and anything about health insurance in that hospital, he's in charge. So please, let's make him welcome.
Thank you very much. Thank you very much. You're welcome.
We also have Dr. V, who is online. Can we check if he's online?
Yes, he's joining.
Oh, Dr. V, can you say hello to everyone here? He's from the NHIS. Also, I don't know if Dr. Fabong will be joining online as well.
Yes.
He's online already. Okay, please let's make welcome Dr. Fabong Yudan. He's the Executive Secretary of Plateau State Contributory Health Scheme. Please, sir, can you say hello to the audience?
Hello, ladies and gentlemen. Good afternoon.
All right, we can hear you loud and clear. So before we start the main conversation, so universal health coverage is, if we know the SDG goals, universal health coverage is goal 3. Actually, okay, great. So before we, I called on Patrick Okibo, who is to tell us a bit about next year health. So can we have Patrick? Okay, all right. So we'll wait until Patrick is ready, and at some point we'll speak to us. All right. So let's get kicking. So universal health coverage. I don't know in the audience and those in online. Can you maybe in one word or in one sentence tell us what universal health coverage is? You can just type on the chat box and we'll possibly read out maybe a few. Just on the chat box for all the audience online, can you tell us what universal health coverage is? And before I also call on the panelists, is there anyone in the audience physically here who would like to tell us what universal health coverage is in his own terms or has? No, don't feel under any pressure, but because it's the core of our conversation today, we just wanted to know while those online are typing in their responses, anybody in the hall who is confident or feel comfortable to let us know what they understand by universal health coverage. But if not, there's no problem. We'll see if we can get some responses from the audience. All right, I'll start with Dr. Francis. While people are responding, so Dr. Francis, can you tell us what universal health coverage is? I know Dr. WHO has been leading that charge on behalf of UN and the whole world. And how do you situate health insurance within the context of universal health coverage?
All right, thank you very much. Universal health coverage is a buzzword, and quite a number of people know about universal health coverage, and the acronym UHC has become a household acronym. So when we say UHC, what we mean is that everyone, everywhere they are, especially in our country, Nigeria, or any country, any community where they are, should have access to the healthcare they need in the quantity and quality they need them, at the time they need them, without having to enter into economic hardship. So what this means is that, so that poor farmer in Uzowani in Enugu State, and the herdsman all the way far away in Sokoto or Jalingo would have access to the healthcare they need anytime. So if that farmer gets bitten by a snake, even if it is at night, that he or she should be able to get the healthcare he or she needs at that time, in the quality and the quantity they need them without having to fall into economic hardship. There is this traditional universal health coverage queue that the WHO has made very popular all over the whole world. And that's what we use in a nutshell to describe and demonstrate universal health coverage, in the sense that before you achieve universal health coverage, so clear, decisive, and sometimes very painful decisions will need to be taken in 3 main dimensions. So number one, is the population to be covered, so what we call population coverage. The second is service coverage, so the scope of services that need to be covered for that particular population. And the third is the extent to which we want to cover the costs of these services for this population. So if you understand the universal health coverage cube in those three dimensions, you would have done very well to understand the principles, the basic principles of universal health coverage. And for us, universal health coverage is a political decision that countries need to take, or indeed for Nigeria, states need to take to be able to bring health closer to the people. Thank you very much.
Thank you, Dr. Francis. Just a follow-up question. I think we can pass on the mic to Dr. Nek.
Okay.
Yeah, so before you finish, I now wanted you to situate health insurance. And then after that, we come to Dr. Neka, because what I always have Dr. Neka, how to prepare is, so what is the UAC goal that Nigeria has set from the Ministry of Health perspective? So Francis has laid the foundation of what the universal health coverage means from the global perspective. But from Nigeria, what is the government doing? What is the government's policy or stance when it comes to universal health coverage? Dr. Francis, now the situating health insurance with universal health coverage.
Yes, apologies, I missed that leg of the question. So, indeed, health insurance provides opportunities for funds to be pooled in a cost-effective manner to be able to purchase a package of health services. These package of health services are indeed essential health services for a particular population. So you can see how health insurance mirrors that UHCQ of population coverage at the base, then service coverage at the width, and then the cost coverage at the height. And indeed, what health insurance does is ensuring that there is prepayment so that people who will, that population that is covered will access that package of health services that you have designed without having to pay out of pocket, without having to pay at the point of use. So that's the basic principles and the connection between universal health coverage and health insurance. Thank you very much.
All right, thank you. Then we will unpack health insurance later. So Dr. Kofi, just be waiting, we'll bring you in. So Dr. Neka, like I said initially, how do we situate, so that what's the government's UAC agenda? And does the government have a flagship program for universal health coverage? And would you let us know what that is?
Thank you very much, Alex. And so coming to is government's, Nigerian government's UAC agenda is broad-based, one after the other. So first of all, on top of this broad-based agenda is the fact that the people are at the center of it. So there is that goal of ensuring that everybody has access to adequate care. And then there is also that agenda, part of the agenda, to ensure that in assessing this required care, people don't go into financial catastrophe. Additionally, the structures are needed to ensure that people have access to this. So putting in place all of those structures. So those are the key tenets of government and UAC agenda for the Nigerian people. Now, to advance all of these is the issue of building partnerships that will ensure that all of these goals are achieved. Because over time, we have come to know that the UHC agenda is a collective agenda that will require collective effort to for any country to move through with it. So having the required partnership across all of the levels, intergovernmental, intragovernmental, the private sector, within the community, and all of that. So all of those partnerships are critical for moving the country's unity agenda. And government is making all efforts to ensure that this partnership, they are built where they don't exist. Where they exist, they also work hard to strengthen them so that they are useful and fit for purpose. Now, over and above all of these, the policy instruments that are required to ensure that all of these that the fine details of all of what we have outlined come through. Because if we don't have policy instruments and laws to advance this, then we'll just be talking to ourselves. So from having the National Health Act, which is a national health law that provides guidance for revamping our national health system, pulling through with our unity agenda and total health system, strengthening. So policy guidelines and other documents, the National Strategic Health Development Plan, which was through the pillars of the health system, and also the National Health Policy, which further provides guidance, and several other policies that could go on and on and on, that provides final details and strategies for us to also improve. Now, in addition, also, the issue of financing all of these strategies, policy instruments, and all of that also is important and is part of the strategies that are also deployed. So looking at the budgeting system, so over time, we've had to go back to look at how we have done it before now, and we have come to understand that providing evidence that will guide our budget processes and our budget system has also been found useful. So we are working currently, there is a process that is going on, which is the development of a financial sustainability plan for HIV, TB, malaria, and of course the national health system.
Okay, sorry, Dr. Neke.
Yeah.
We'll come back to financing.
Yeah.
What I wanted to ask is, with respect to UHC,
Yes.
so which program or project is the UHC flagship program we have? For instance, can you tell us a little bit about the current program, the Basic Healthcare Provision Fund, and then we'll now, after that, we'll come back to financing and then also delve more deeper into the health insurance.
Yeah, so Dr. Felix, you will understand that considering the complexity in our health system, you really cannot single out, one process or one strategy. It has to cut across. Otherwise, it will negate the spirit of universal health coverage of leaving no one behind. So that is the reason why we would have to take all of this precisely. So yes, the National Health Law makes provision for the Basic Healthcare Provision Fund, which the leadership of the Ministry of Health has taken as the flagship cause for unity. But in addition to that flagship cause, there are also some additional interventions that would support the BHCPF and further expand the scope of the BHCPF, because the BHCPF does not answer it all. It's supposed to provide for a basic minimum package of healthcare, and considering epidemiology, various diseases, and all of that, you know that it's only right that whilst we are advancing this basic minimum package of healthcare, we should also consider the population base and what epidemiology would play out. So the basic healthcare provision fund is a provision of the National Health Act that is supposed to be financed from three main sources that the law had outlined. Like we said, it does not answer it all, but it just ensures that every citizen of Nigeria has access to a basic minimum package of healthcare that is affordable, especially for the vulnerable group. So over time, a basic package has been defined, but this is premised on the fact that as the resources, the physical space expand, that basic minimum package of healthcare can also be revisited and can also be expanded. In 2014, the law was passed. It took a couple of years for the implementation of the law and to also ensure that I'm tempted to talk about the money. You said we talk about the money later, but so we need money to implement the BHCPF. So it took a while for us to get funding for the BHCPF. And because the law had also mandated that the funding for the BHCPF will not only come from government. So governments demonstrating commitment and leadership also prompted other stakeholders to start investing in the basic healthcare provision fund. We're not there yet, but just to say that at least we have taken that initial big step as a country to use the basic healthcare provision fund implementation as the first strategy to ensuring that our people have access to universal health.
All right, thank you, Dr. Nneka. Madam UAC, she's giving us a lecture already on UAC. All right, thank you, Madam. Now, Dr. Kofi, I want to bring you in. She has talked about the Basic Healthcare Provision Fund, but we also know that there is a component that is connected to insurance. So I want you to help me or help the audience understand what is the role of NHIS in the implementation of the Basic Healthcare Provision Fund. What is, I know I've heard about the NHIS Gateway, NPSA Gateway. Please, can you tell us what NHIS is doing for the implementation of its component of the Basic Healthcare Provision Fund? Because it speaks to financial risk protection component of US. Over to you, Dr. Kofi.
Okay, thank you, Felix, and good afternoon, all. So let me just start by saying the Basic Healthcare Provision Fund, to me, is the single most important public health intervention that this government has done. It is a program that is capable of transforming, or is already transforming, the landscape of healthcare delivery in Nigeria. One of the key factors that are driving morbidity and mortality in Nigeria are anchored on poverty. And we all know that the ability to pay, is one of the most important variables that has led to a lot of people to their early grave because they cannot access, healthcare. So the BHCPF, as said by Dr. Nneka, is a very important and very innovative means of financing healthcare, where the government brings out 1% of the CRF, that is Consolidated Revenue Fund, plus minus other sources, of funding to ensure that, healthcare is provided at the basic or the grassroots level. So this fund is divided into three. 50% of the fund goes to the NHIS, which is the so-called NHIS Gateway. 45% goes to the primary healthcare gateway, which is the NPHCDA gateway, and the 5% for the emergencies. So for the NHIS gateway, our focus is to ensure that healthcare is purchased for the most vulnerable groups of the population through a decentralized health insurance system. So you are aware all the 37 states of the federation have some form of health insurance agencies, with various level of functionality. These health insurance agencies are supposed to serve as avenues where enrollees will be enrolled into health insurance, and payments be made for their services for them to access the basic minimum package of healthcare services. These healthcare services are a range of curative, preventive, and rehabilitative services, that are actually developed, taking into cognizance the prevalence, the prevalent causes of morbidity and mortality in our own land. So this is basically what the NHS is supposed to do: work with the state social health insurance agencies, enroll vulnerable populations into health insurance, and ensure that these services are paid for so that these people access qualitative, affordable healthcare services without suffering any form of financial hardship. This is basically the NHIS angle. Thank you, Felix.
I know we started implementing the National Health Insurance Scheme since 2016. So
yeah.
Nigerians would like to know, where are we with respect to the coverage of Nigerians? I know previously, maybe some years back, we say it's 3%, 5%. Can you give us an idea of the level of coverage of financial risk protection through health insurance in Nigeria currently? And then we'll speak to state representative here and our colleagues from the FMC to get their perspective of how the insurance schemes progress in Nigeria.
Okay, so thank you, Felix. This is a very important question that I always like to be asked, because if you look at one of the key challenges facing Nigeria, has always been the ability to cover Nigerians with health insurance. The NHIS, no doubt, is one of the most important, if not the most important institution that is supposed to anchor this drive to cover Nigerians with health insurance. I'm happy to say that due to the ongoing reforms going on in the NHIS, today we have an NHIS that is focused, stable, and very much result-oriented. We have an NHIS that is undergoing rapid reforms, in various sectors, in order to ensure that all Nigerians have access to health insurance. For the first time in the history of the NHIS, we have developed a 10-year strategic plan that has in detail, let me use that word again, how Nigeria is going to achieve UHC. So, you cannot go anywhere if you don't have a plan. So for the first time, we have a plan. And the second time, also, I have to say, we have a leadership that is versatile, result-oriented, and focused on implementing this plan to the latter. But more importantly, one of the most important developments as far as health insurance is concerned is the decentralization that has happened. You are aware that enrollments are happening across all the states of the Federation, almost all the states of the Federation. Some form of enrollment with health insurance, either under the Basic Healthcare Provision Fund or the formal sector programs of these states is currently ongoing or has been ongoing for the past series of years. So I'll tell you that the coverage statistics have increased because of this coordination that the NHIS is providing, and also because of these innovations that are ongoing, both through the BHCP and other aspects of health insurance coverage that are happening. So yes, the NHIS, before we can say the coverage was not much, but I tell you that now the figure has actually gone higher. Thank you.
All right, thank you, Dr. Kofi. I'll bring Dr. Fabon to share his perspective. Dr. Fabo, can you hear us?
Yes, I can, sir.
All right, excellent. Thank you for joining from Jos. Now we want to hear from you. Dr. Kuri has said that due to the decentralization of health insurance, which happened in 2016, that states have contributed to expanding the coverage. Now, since you are the CEO of the Plateau State Health Insurance or Contributory Scheme, as how would you describe your experience, trying to expand health insurance in your state? You can also leverage the experience of the other colleagues. I know that you're a member of the Forum of CEOs of State Health Insurance Agencies. So can you share with us what has been the progress? Are there challenges states have been facing, or what's the progress? Do you think that the state, through state health insurance schemes, will be able to achieve UAC in Nigeria? Because the target for UAC is 2030. So do you think through the work you guys are doing in the states, we'll be able to provide coverage to at least majority of Nigerians that are poor and vulnerable, who may not be able to pay for services by themselves?
Oh, okay, thank you so much for those numerous questions you've asked. I will attempt to give some. You're laughing, yeah. I will attempt to give some expose on those questions you asked. First, let me start by congratulating Nextia for creating a platform for Nigerians to get to understand health insurance and the way forward. I must confess that the 2014 National Health Act had given a bigger template for the NHIS to work towards achieving universal health coverage in Nigeria. And suffice to say that after the 2014 National Health Act, a lot of states started creating the State Social Health Insurance Agency, and the Plateau State Contributory Healthcare Management Agency came into being after the 8th Assembly passed the law in May 28, 2019, and His Excellency, the Executive Governor of Plateau State, the Right Honorable Dr. Simon Bakola, along KSGG, gave his assent June the 3rd, and the Plateau State Contributory Healthcare Management Agency was established. And we kicked off in September of 2019. And as Francis Sekuje had mentioned, we are saddled with the responsibility of seeing through the realization of the United Nations Sustainable Development Goals of achieving universal health coverage, which entails preventive, promotive, curative, and rehabilitative services at a cost that is affordable. Now, the experience has been an amazing experience because through the 36 states and the FCT, we share common experiences, and we have often met at the forum of the chief executives, and we've discussed some of these experiences, the challenges we have, the gaps that are, and then we are making progress with the technical working group of the NHIS that has been very, very supportive. Now, here on the plateau, we've been able to enroll over 44,202 principals in the formal sector, and that's the state civil service, and we've been able to enroll 14,023 principals alone in the local government service commission, excluding their dependents. And when we started this process, remittances of or the payments of the premium for civil servants at the state level had been consistent from January 2021 till date. And we have also created channels for service delivery, particularly using 325 primary healthcare centers across each of the state wards and the plateau. And then we have about 74 public and private facilities accredited to offer primary and secondary services. And we also created the minimum benefit package of health services, and we've contracted health maintenance organization to help us with referrals and claims management. But to a large extent, we had enormous challenges because health insurance is one very difficult thing to sell. Some people have a poor understanding of what health insurance is, and someone would ask you, why do I need to buy a casket and keep because I'm going to die someday? And they ascribe paying premiums for health insurance as something very difficult. People also find it very difficult to reconcile the fact that at the end of the year, if they do not fall sick, will their premiums be returned to them or not? And it may also interest you to know that a lot of people are still not in the know of what health insurance is all about. So the successes that has been registered or recorded by the National Health Insurance Scheme is largely due to the fact that we have state social health insurance agencies that are enrolling people every day. And then, of course, we are linking our database to one. So part of the challenges we also have is adverse selection from enrollees, particularly of the informal sector, and that is posing great threat to the pool that we have. And then we also have issues of non-release of equity funds across the various states, but the NHIS, the executive secretary of the NHIS, Professor Nasir Sambo, had taken that up, and he has written most of the all the governors of across the nation to do well with payment of the equity funding, since the Basic Healthcare Provision Fund has been coming to help through these processes. And of course, part of the challenges we also have is delayance of issuance of what we call authorization codes for access to care at secondary and tertiary levels by health maintenance organization, which has been a problem over this period in review. But we have as well made some significant progress with some of these challenges, particularly in the place of awareness. And here on the plateau, we've reached more than 1,000 different interest groups from the start of the agency. We have reached out to mostly people in the informal sector in their clusters like the Market Women Association, All Farmers Association, Tricycle Union Riders of Nigeria, NURW, and there are so many groups in that regard. We've taken, we went around the entire 17 local government of Plateau State with sensitization meetings. And we met the traditional council, we met largely people in the informal sector, and then we have sustained a weekly engagement on the radio. But one most important part that we've made great success is meeting our federal legislators, which we have 8 in the Federal House of Representatives, and we also have 3 senators, and we have sensitized them adequately, and we have also advocated on behalf of the people for procurement of premiums for their constituents as part of the constituency development projects. Now, we have also reached Plateau citizens both at home and in the diaspora, and some of them have procured premiums for people in the informal sector. Overall, I can say that we have reached 50% of the population on the plateau with our sensitization and advocacy meeting. Now, prior to the start of the state social health insurance scheme, I can tell you that the level of coverage of health insurance has been on the low. But from the baseline survey that we did, we have 4.7% of the entire population on the plateau now covered by this health insurance. So we are making significant progress, despite the fact we keep having challenges here and there. And then you have the issues of adverse selection, which are some of the challenges we've had over this period in review. But our work at the forum, doing some let me say comparative studies within ourselves, and then doing the constant meeting we've had also with the NHIS have helped us largely towards navigating some of the turbulent areas that we have in operationalizing the state social health insurance scheme.
Thank you, Dr. Pamo. That was helpful. Now we have our brother from FMC. So the NHIS or the state health insurance scheme can tell us, but we want to hear from those who are providing the care. Those who NHIS and the state health insurance schemes have been engaging, they interface with the health maintenance organizations, and they're the ones that pay them and all. So, Dr. Ephraim, please, can you give us an idea of what it has been like to provide health insurance from FMC?
Yeah, thank you very much. I want to acknowledge that I am here representing my medical director, who has asked me to represent Professor Sad Ahmed. Yeah, it's been a wonderful experience. But, Federal Medical Center Abuja has been offering services under the NHIS platform. On the NHIS platform since 2014. We have progressively grown to the point where we are overstressed by requests. And currently we are not accepting new enrollees at this time, pending expansion of our capacity. This is official. We have communicated the NHIS on that, and they know. So I'm saying that to address the fact that it's actually a success story, irrespective and notwithstanding the shortcomings and the challenges which I am sure you may like to dwell on subsequently. So that's the experience we have had. It's an interesting experience. We have recorded successes. Maybe I'll address your questions as they come.
Okay, so the HMOs, Dr. Fabo mentioned a little about HMOs. So what's the experience working with HMOs? Do they pay you guys on time? Do you get authorization codes when they are due? And then there's also this complaint. I'm saying this on behalf of Nigerians, is enrollees that when you go with an NHIS card to the hospital, they keep you somewhere, and it's kind of drugs they give you, you feel a lot of patients feel they are not drugs of high standard, high quality and standard. What can you say about that?
Thank you very much. You will notice that we have progressed from the policy, document handling, and into the field. We are now practical. So we would not like to dwell on hearsay or speculations. We are talking about what is happening in the field. I will use my center as a typical example, which you can verify even as we are speaking. Federal Medical Center there has a dedicated unit that attends to National Health Insurance Scheme patients. I represent the leadership of that unit as a consultant family physician. And that's basically the clinical work that I do on a daily basis. And to pay consultants every month to attend to health insurance patients, it's a big deal. I don't think a private healthcare facility would dedicate a consultant to do that. Now, as I speak to, we have at least 7 doctors that work in this unit of all kinds, from medical officers to registrars to senior registrars. So it cannot be anything less than what any other patient is getting in the hospital setting. Coming to drugs, the NHIS has specific rules. The only thing that is contentious is branded and unbranded drugs, medications, pharmaceutical products. And that is what the NHIS has said. It doesn't mean that generic products are of any less quality. The big multinational pharmaceutical companies, their prices where they will be able to satisfy their stakeholders and shareholders. But we have very high quality generic preparations that we use to serve our patients. We have dedicated pharmacy for patients who we care for on the NHIS platform. We also have dedicated laboratory. And so, if anything, I can tell you authoritatively that NHIS patients are doing optimally very well. We attend to upwards of 4,000 patients in a month on the platform of NHIS. And we do audits of these patients. It's a training institution. Up to this morning, we audited our patients to know how we are caring for them. So it's a fallacy to even say it, that health insurance patients are receiving less quality. But then to any further question, because I will keep it complete.
So,
Thank you.
you know, why it was important is for Nigerians to know that generic drugs, if you are giving a generic drug, it doesn't necessarily mean it's of poor quality. So I think that was the point I wanted to make. I already made it. Now, Dr. Francis and Nneka, we'll be coming back to you in it. Just one quick thing I wanted Dr. Kofi to say. I'll come back to you. So, Dr. Kofi, I know NHIS is doing something about this issue about drugs. Can you just, in the next, just within 2 minutes, tell us what NHIS is trying to do with respect to the drugs that patients are given? And just to let Nigerians have an idea what the NHIS is trying to do to address that perception, because it's a perception that the drugs giving and all. So, can you just quickly, then we'll come back to Dr. Francis and Nneka.
Okay, thank you, Felix. And thank you to the doctor from FMC for shedding light to Nigerians that branded and generic drugs are not in any way different. You know, but still in the NHIS, under the leadership of Professor M.N. Sambo, we have come up with what we call the NHIS Medicine Supply Initiative. And this medicine supply initiative is a very novel idea of trying to produce NHIS branded drugs. So these NHIS branded drugs, we are going to aggregate pharmaceuticals companies and other private sector to leverage on the large population of the enrollees that we have in the country, and then leverage on that economy of scale to negotiate prices down for our enrollees so that we can bring down the cost of drugs for not only for the enrollees, but for the hospitals. But we also ensure that we have direct contact with pharmaceutical companies that are producing these drugs. So we are 100% sure of the quality of the drugs that have been provided to our enrollees. So under this NHIS Medicine Supply Initiative, we are targeting, massive rollout. We're happy to inform that the minister has given his approval for this novel initiative to commence soonest. So massive rollout of this initiative is going to happen, and we are going to ensure that our enrollees have access to quality and affordable drugs, at a very subsidized rate, using the branded NHIS platform. So that's briefly about the NHIS Medicine Supply Initiative in brief. Yeah.
All right, thank you, Dr. Kofi. I wanted Dr. Ephraim to also know, so that providers will know that NHIS is also making efforts to kind of think, not just to provide more like drugs that Nigerian citizens will be very happy with. All right, thank you. Still on the insurance, Dr. Francis and Nneka. So both of you just hold the microphone. So Dr. Fabo talked about the benefit package and the experience is that for each country, a country will have a benefit package. So what are the principles that have kind of guided Nigeria to develop the benefit package for BACPF, the one that the states are doing? So I just want maybe the next couple of minutes that Nneka, you share with us. Okay, Francis, from WHO perspective, in terms of the service coverage, what are the expectations? What WHO expect from countries? And then Nneka will now tell us how did Nigeria define the benefit package for BACPF? Then we'll maybe briefly, Dr. Fabo will talk about how states define their benefit package, and then Dr. Kofi will tell us what NHIS is trying to do to expand the current benefit package. Okay, Dr. Francis.
Francis, you have to come. You have to come again. We didn't hear you.
Okay, so I said, can you hear me now?
Yeah,
Yes.
perfectly well, sir.
Okay, so I said that, there is no insurance. Even when we pool resources, if those resources do not target provision of quality essential health services to the people. So even when we are successful at getting monies together, so if the people are not receiving services under insurance, then that insurance is deemed to have failed. And perhaps that's where the question that Felix asked about the extent to which providers have actually satisfied that aspect of insurance that they are required to do in terms of service provision. But before we even get there, so we would need to specify what services that need to be provided. And based on that decision that is taken, like I said earlier, that also borders on the political economy, it is useful for countries, or indeed in Nigeria, where we have decentralized health insurance, to take decisions on what scope of services to be provided. And this is based on to your question right now. Number one, the population to be covered. Of course, that population should also be defined. Second is the population need. So in that particular population, take a state like Plateau, because we have Dr. Fabon with us. So what are the peculiarities of Plateau State population? So is it made of mainly adults, mainly aged people? Is it mainly made up of children? Is it mainly made up of adolescents and the younger population? That is one, the population mix. The second one is, we will not get into it, the burden of diseases. So the burden of diseases in that environment is important in determining the benefit package. Of course, sometimes a lot of people will want to follow the birds in the whole world. So let me take, for instance, and this is not supposed to be taken out of context. So let me take, for instance, HIV. So HIV at some point was everywhere. And then I see that a state like Sokoto State has put HIV in their benefit package. And Plateau State does not have any need for HIV because in their population is not a disease of public health concern. And then they copy the benefit package of Sokoto State and begin to provide HIV. It doesn't make sense. And this can happen also in the various other diseases. So the burden of disease is important in determining the benefit package because it is supposed to provide essential health services to the people. And then I come to the next criterion for determining benefit package is funding. Again, it is not necessary that any government would decide and put into the benefit package the kind of diseases. Let me take, for instance, cancers. And then you put them in the benefit package because, and you know that if one person assesses that care, it clears the whole reserve. Then it doesn't make sense to put that in the budget. If you don't, then you wouldn't be able to finance it. So in a nutshell, these are some of the key guiding principles and criteria for determining a benefit package of any country or indeed any state on health insurance. Thank you.
All right, I'll pivot a little, but like it's still on financing. Before we said we are coming back to financing. So even if you don't go deeper into the benefit package and all, Francis has spoken extensively about that, so we don't necessarily have to belabor it. Now, so with the benefit package that we have, whether it's PHCPN, ones at the state, or even the NHIS one. So what's the physical space like? Physical space, do we have the money in Nigeria to pay for these packages? And to ensure that we actually achieve UAC? Are we rich enough to provide UAC for Nigerians, or do we need to task everybody to make sure that we all contribute as Nigerians into one pool and then we use the money to pay? I'm just joking, but like, what's the physical space for health like in terms of providing the care that we have in our benefit package for Nigeria, UAC, as part of the UAC group?
Right, and thank you very much. So, yeah, I don't want to go through all that Francis has outlined, just to reiterate that in defining the benefit package for Basic Healthcare Provision Fund, the Ministry of Health also, took all of, if not, took most of, if not all of those steps in defining the benefit package. So coming to the question of if we have the money to ensure that Nigerians have access to universal health coverage. There are a few guiding principles which we must have to look at before we say a yes or no, because it's actually not a yes or no question. UHC is a journey. UHC has to get country ownership. It has to be defined by the country based on their peculiarity. They have to look at what works for them, what is visible within their space. So there is really no global template for saying it must be A, B, C, D, F before it is a George universal health coverage. But just to say that as a country, we have looked at the available fiscal space as a then, also considering that the fiscal space is very, it is not static, it is dynamic. What it is this year may not be what it will be for next year, and like that. So we have to look at all of that and make adjustments for that. So that will mean that whatever benefit package we had proposed or put into place then, we looked at implementing and upscaling using a phased approach, of course, based on what was available. So the belief is that over time, we will be able to cover everybody. But of course, we started prioritizing, looking at the vulnerable, initially. So, yeah, so that's just to say that at some point, we started with a certain group in the system, having developed that framework, and then handing over to states. And of course, each state, based on their own available fiscal space. Remember, the one coming from the federal was just like, it's a minimum package. And because of the governance structure, states have that power to make decisions on how and where to put their funds. So they were also at liberty to expand on that minimum package. Back to what Francis has said. Depending on their epidemiological outlay, depending on the needs of their people. So they would also have looked at, what are the most needs of their populace before doing it. So it's a tricky one to say that, whether we have money to, we're using that phase approach. But for me, I think over and above all of these, it's not particularly about the pot of money. It's about how efficient are we able to use what we have to ensure that everybody have access to the required care as at when needed. So we have tried to plug in those strategies to ensure efficiency. Right now, the buzzword is around strategic purchasing. How are we strategically purchasing these services to ensure that it is cost effective, the people who need it most will get it and at what time, without also using, also leverage existing structure, just for cost reduction and making sure that cost-effective strategies are deployed to ensure that everybody gets access to a basic package of healthcare. So I strongly believe that as a country, we will continue on this trajectory, increasing, expanding health insurance coverage, upscaling the package at every point. 2030 is by the corner, but it doesn't look like it is not doable. That political will, that commitment will continue to better that and upscale, making sure that we'll continue to push. And by the way, it is the election year, so it's also another opportunity for us to push and make sure that we hold our politicians accountable by pushing forward to ensure that health is on the political agenda. So with that, it's also our strategy for advocating and making sure that we get resources that will ensure that UHC is achieved.
All right, thank you, Dr. Meka. Most times we complain, those of us in the health sector, we feel, oh, we are not getting enough money from the annual budgets. But the other bit is the budget we get. And why I'm saying this, I recall early days before BSP, the implementation started, we were doing a study on health financing landscape. So I went to the Ministry of Budget and National Plan to talk to some of the policymakers there. We wanted to understand their perspective. And one interesting thing that I was told was that we know that the government is, if you look at it, that the health sector is receiving a whole lot of money, in the sense that think of the number of teaching hospitals we have and all of that. So they were trying to say that we spend a whole lot of money, but it is not necessarily going to where the needs are. So the primary health care level and all. So then the issue is, so Dr. Francis, why I'm saying this is, so if we analyze the annual health budget, we probably will see that majority, maybe I'm just saying it loosely, maybe about 70% goes to tertiary healthcare. And this came out clearly, the Basic Healthcare Provision Fund, the Federal Oversight Committee, one of the meetings late last year, it came up and someone was actually brought up that idea, said, we focus on just a small component that goes to the Ministry of Health, but a larger part goes to the parastatals and agents. So do you think that's an efficient way we are using the money that comes to the health sector? Should we channel the money we get for health sector through insurance? And I know Dr. Pablo will be very happy to hear that, or Kofi. What do you think? And Dr. Nega, do you think this, maybe Francis finish, we'll also ask you, and then Dr. Ephraim, that works in the hospital, will bring you in and ask you essentially something about that.
Yes, from our experience and from data, we know that health sector money in the health sector in Nigeria is mainly spent at the tertiary levels and the secondary levels, with the primary health care receiving between 20 to 30%. And of course, this is national average. There are some states where primary health care spending is really very much less than that. It should be the opposite, because what we have in the package of health services are essential health services, which primarily should have been provided by the primary healthcare centers. And so Dr. Meka and the National Health Accounting actually did a very small but very impactful analysis that showed that actually primary healthcare is not provided at the primary healthcare centers. They're rather provided at the secondary and tertiary hospital, which makes it more expensive and indeed less efficient in managing. Now, if you take a step forward, so the question is, to what extent are we putting our money where our mouth is? And we believe that some of those anomalies in the system in terms of financing or package of health services can be corrected if we have a functional health insurance scheme. Perhaps we need to remind ourselves that what underpins functional health insurance is one, that the health insurance is mandated. What it means is that nobody opts out of it, so it covers everyone. Second is that there is something that is called cross-subsidization. So what it means is that those that are poor are covered even when they don't have money, but those who can pay would have to pay and are able to also support those who are not able to pay, because those who are not able to pay are usually exempted. And then last one is what we call risk equalization. So what that means is that, so those who are sicker, of course, we know the principle that those who are poorer are sicker, that they are not allowed to suffer more, but because they are taken care of, because the contribution of others takes care of them. Now, if we need to ensure that this works, that redistribution happens very much around health insurance, and that's why we are very passionate about supporting health insurance to happen in the country. If health insurance works, what it means is that premiums of funding is channeled to primary health care. Indeed, it also underpins the principle around the basic health care provision fund. So the NHIS or the state insurance agencies channel monies to the primary health care centers. And in doing that, they use their function of coordination and regulation to ensure that those primary healthcare centers have the quality that is needed to provide those services to the people. I'll just give you a typical example. I went to a particular community. This is in December 2021. We had community engagement with those who are covered on insurance for the last 2 years. Almost everybody, over 80% of the people, are aware that health insurance is important for them, and indeed are grateful that they are covered on insurance. But they are saying that they don't want to continue. Why? Because the services that are provided in those primary healthcare centers are not what they need. And of course, a lot of them say that if it is this thing that we are going to continue with, please, let's not continue. And those of them who even don't have much money said they won't go there again. Rather, they will have to sell their property to go to a place where they will pay to be able to get quality health service. This is how important it is for us to ensure that although we channel monies towards primary health care, we need to also ensure that we use our regulatory levers to ensure that those primary health care centers, or indeed even private health facilities, improve on their quality to be able to provide services to the people. Thank you.
All right, thank you, Dr. Francis. I think we've been talking, so we would like to, maybe before we go, let's see if we'll be opening it up to our audience, at least to see if there are questions or comments they want to make before we are finished by 5 o'clock. So we still have some time, but we would like to see if there are some key questions or comments from the audience. Oh, okay. Thank you. Okay, we have some questions that we will use now. Great. I was about to, the next question I was asked us was about informal sector, and the audience already are pushing towards that because of what Francis just shared. So, Dr. Kofi, one question that comes, and I think maybe Fabon, if just quick answers, like NHIS have plans for the informal sector.
Yeah, so thank you very much. I think that's a very important question. And I was also reading the comments online, and there are a lot of discussions actually going on around the informal sector. The informal sector has become a very hard nut to crack, for the health insurance system in the country. I'm happy to inform you that the NHIS does have plans to actually cover the informal sector. Number one is leverage on the basic healthcare provision fund, which you also know is targeting the informal sector. The second one is also to look at how to scale up coverage among the non-poor informal sector. So one of the most important things we need to understand regarding the informal sector is that before you cover that sector, you have to understand that sector. And so the informal sector in Nigeria has a lot of peculiarities, but both the non-poor and the poor informal sectors, the NHS has devised mechanisms to cover that group of vision. For the non-poor informal sector, there's a program called GIPSHIP. That is the Group Individual Family Social Health Insurance Program that has been rolled out by the NHS, targeted at covering, that class of people. For the poor informal sector, the Basic Healthcare Provision Fund is actually massively enrolling that sector. So I think we're making headway as far as covering the informal sector is concerned.
Okay, thank you, Dr. Kofi. Just a quick one on the benefit package. So some people are asking that is there any plan to include some services that ordinarily maybe you wouldn't expect in the basic package. For instance, mental health and maybe rehabilitation and a few others. So maybe Dr.
Yes.
Can you speak a bit about that? And then Dr. Kofi, and just because it's a question to the government, so you and Dr. Neka from Ministry of Health and NHIS, I think this is your word now.
Yeah,
Thank
so
you very much.
Neka.
Okay, Dr. Maybe Neka goes first, then you will respond.
Let my younger sister go.
Okay, so in responding to that question, so there is what we call an essential health benefit package, and then the minimum health benefit package. So stemming from the National Health Act, which made provision for the minimum benefit package. That was defined, showing that it's the barest minimum. This is what every citizen of Nigeria should have access to. So, but in developing the National Strategic Health Development Plan, there was also an opportunity to develop what we call the Essential Health Benefit Package. So the Essential Health Benefit Package is really broad-based, using the WHO building blocks. It just goes all of the way. So it is wide, it is broad-based, and what in developing the National Strategic Health Development Plan, that essential package was, different scenarios were looked at and costed, so those different scenarios will take care of whatever need, whatever ecological outlay, that's there exists. So in that package, there's one word I'm looking for. There's need to have, nice to have, compulsory to have. So the minimum benefit package falls within what compulsorily every Nigerian should have. Whereas the essential benefit package, which looks at cancers, mental health, reproductive health, in-depth, like that, is, yes, it is nice to have, but that will be dependent on the available fiscal space. And that was why different scenarios were created, and of course costed. So I think at the launch of that document with that essential benefit package, it was costed, if I remember, for the 5 years that it was going to be implemented, it was going to cost about 6 billion naira. So it is now the choice of the country to look at how to galvanize resources and make provision for that. But just to say that the essential benefit package is the global one, is the big one, where the minimum benefit package is drawn from. And as we work on expanding the benefit package, we draw guidance from the essential benefit package, which is further broad-based and available to states that can afford it depending on their fiscal state. And so, yes, we cannot say that mental health and all of those, but that oral health and just name it, they're all included there. That is premised on the availability of funding.
All right, thank you. Dr. Kofi, just hold on a bit.
I just want to add that what is most important, as said by Dr. Nneka, is the issue of resources. As much as the NHIS would have loved to cover every available service in the benefit package, we have to do a lot of financial sustainability analysis and a lot of thinking behind what goes into the benefit package of the NHIS, bearing in mind that whatever service is included in the benefit package can never be dropped. Once you include a service, you have included that service for life. And also when you put a service, you are putting it for the entire population of the country. So it has a very huge economic implications for any service we put. And so the other issue I also want to say is that including in expanding benefit package is something that is done gradual. You start from the basic and then you scale up as your resources accumulate over time. As you get more resources, as you invest, you try as much as possible to scale up your benefit package. I want to inform this House that just this year, the NHS has been able to include some specific cancer services in the benefit package based on a partnership with Roche Pharmaceuticals. This is a very innovative way of actually trying to see how we can reduce on a cost-sharing basis, where the enrollee pays certain amount, Roche pays certain amount, NHIS pays certain amount. So the space for private sector participation to deepen the benefit package of NHIS is also there. This is just for information purposes also, but I also want to hear from the state social health insurance agencies. How are they doing with regards to benefit package? Because I do know that the resources we have at our disposal in the NHIS is far, far more than what the states have at their own base. So maybe Dr. Fabon can say something here just to shed more light. Fabon.
Thank you, Dr. Kofi. I think I've been listening keenly and learning a lot also from that process. The benefit package for most of the state social health insurance scheme was determined by a combination of path dependency, cost effectiveness analysis, and social values. And Dr. Francis Okudie had described what path dependency means. We used the NHIS initial template. And of course, we also considered the greater proportion of people benefiting from the resources and a way that it does not drain the financial resources of the scheme. And by social values, for instance, us on the plateau, we included snake bite management in the benefit package, and upon an assembly of stakeholders who validated the minimum benefit package and understood that that intervention will do more good to the people living in the southern part of the state. And so these are some of the factors most of the states have considered in creating a minimum benefit package of health services. But to a larger extent, I believe they looked at the morbidity and mortality of their states and then look at these diseases that are common to their people vis-a-vis the premiums that they have collected. And from the actual analysis that most of the states have done, it led people to creating a robust minimum benefit package of health services that will take care of the basic needs of the people that we have in various states. Thank you.
Yeah, thank you, Dr. Fabon. That was actually a question one of the audience members had already brought, so it's already answered. Now, just one other question that comes that came from the audience will be also of interest to Dr. Ephraim, but Dr. Kofi will need to answer that, and Dr. Nneka as well. So last week we saw I just received this forwarded message on WhatsApp. that healthcare providers in Nigeria have come to say they don't want to be covering people within private insurance because the benefit package, like the amount they are paying for premium is not, because costs have gone higher and that they need to adjust, and all of that. So the idea now is, Dr. Kofi and the state insurance case. So how do we tackle that problem where the health providers are checking that they are spending more for the services that they are rendering? Since we were having this problem more in the private sector, private insurance, I don't know if, but Dr. Francis, Dr. Fabo, just one minute, can you quickly respond to Dr. Nikas, can you quickly respond to that question?
The private.
The hospitals came from providers.
Providers.
Okay,
From the providers, yes.
Okay, but they don't want to. Sorry, I didn't get it. Sorry, I want to.
Okay, so I'm trying to say last week there was this, it was all over the news, like on WhatsApp, like forwarded several times, that the National Association of Healthcare Providers have written to the Healthcare Management Association, that's the HMO, that they don't want to be providing services for them under their private insurance, that they are not paying them enough or will be paying them late and all. So like this is a problem if people are having difficulty enrolling in insurance, and then the providers who are the key stakeholder who, because they are the ones that provide the service, you buy the service from them. So if FMC say, I don't want to health insurance today, what are they now? So what do we do? How do you think that issue can be tackled?
I think this.
Yes.
Food for thought.
Yeah.
Or but please, senior brother.
Okay, so I think I would, yes, and I think what is most important is for us to really understand that universal health coverage is not just about providing access to care, but quality health care. That publication brought to fore the issue of quality as an ingredient, of universal health coverage. I cannot, what do you call it, say that the report is true or not, so I cannot really comment on it. But what I can say with all certainty is that I do know economic factors like inflation, devaluation of the naira, among others, have affected the prices of commodities and healthcare commodities inclusive. And this was what led to the NHIS to review our prices of our services. Just recently, there was a 30% increment, along the entire services that NHIS provided, because we took into cognizance the inflation, that we're talking about, and these reviewed prices have all been sent to our hospitals and has since been taken effect. What I want to also say is that I think we shouldn't also discard the profiteering motive of some healthcare facilities, because it is one thing you always hear somebody say that NHIS pays only $750 per enrollee, and that same person that has X number of enrollees. I want to give an example. I was in a teaching hospital, making a presentation, and the CMD says NHIS pays only $750. And I said, sir, just last month, if I calculate how much you have received in capitation, because he has about 30,000 enrollees in that hospital, 750 times 30,000, how much is that amount of money coming into that particular hospital? So yes, we do agree that there is need for adjustment in prices of services, but there is also need for hospitals to actually reflect on realities of what health insurance is all about. It's not about individual contribution, but about cumulative contribution. And lastly, I think to the enrollees, what we need people to report if they are not happy with the services they are provided. But when you go to a hospital and you are provided services that you are not happy about, instead of tell the NHS so that we can go ahead and make corrections, you keep quiet and then you either go on social media or kind of stuff, and then that gives a negative impression. The more you report, the more we correct, and the more things get back to normal. And then so that's what I also want to say regarding that. Thank you.
Okay, so thank you very much. So, like I said, this is food for thought for, every stakeholder within the space. So for me, basically, this is where strategic purchasing comes in. This is where adequate regulation comes in. Just like Kofi had said about a certain CME who receives capitation, and we know how capitation is. So whether you give the service or not, as long as this person is here. So for me, that's inefficiency. So it could be revisited because you're receiving money for what you did not provide. In as much as we want to incentivize this provider. There could also be a roundtable discussion to understand that, look, the macro-fiscal landscape is changing, and as such, there should be an agreeable modality for also making adjustments. So, and also NHIS clearly understanding their regulatory role and taking it to the next level. It's very, very important at this point. Because if you do not put your monitoring and evaluation structures up adequately for you to know what and how, where to make adjustments, it becomes problematic in terms of regulating or people at that level. So in as much as we don't want to say we would not do private health insurance, does not mean that we should be afraid of taking decisions, because at some point it will also affect people from the government health facility. So that is where regulation is very important, strategic purchasing very important. We need to start looking at how to strategically buy these services, how to do bulk purchasing such that we move away from paying for what, having high prices because we're not buying the right quantity or we're not buying from the right people. So all of those strategies, should be revisited at this point, and that's why capacity at that level, people at NHIS, is critical for them to understand the dynamics and how to use this instrument at this point to, visit some of these challenges.
All right, thank you. So on the issue of regulations, I think we'll do a bit on that. So Dr. Ephraim, as a health provider, we do understand that sometimes you're expecting maybe referral codes from HMOs, or you want to get, maybe there's an emergency and you need to treat and all. So can you share with us some of those experiences you guys have? And then how can government, whether NHIS or state health insurance, can help so that patients who need the services, they are not delayed because of referral codes? And so what's been your experience? And then how can we, so the question will now be to NHIS and the state agencies, what they are doing to ensure that HMOs release referral codes and also pay the health providers at the right time.
The point is this, just NHIS operational guideline. That's whatever is done within the scheme. Yes, time allowed for retrieving codes from the HMOs. But majority of the time, patients don't know this. And so they resort to complaining, outing, and all that. The NHIS operational guidelines allow 24 hours for retrieval of code. In instances of emergency, you are to give life-saving services and then retrieve the code subsequently. So there's no gap in that. It's a question of understanding what the rules of the game is. Yeah, there are challenges, of course, but overall, the HMOs are trying their best, apart from human factor, which is not systemic per se. So it's not a system problem. If somebody is supposed to be on duty and he or she prefers to leave his or her duty post to engage in other things rather than doing what they're supposed to be doing at a particular time, it's not systemic, it's individual. So it's up to the system, the employer, and whoever else is supposed to be supervising the service to ensure that the things are done rightly or correctly. There's another leg of the question.
Yeah, I mean, it's still related to maybe delays in payment. If there are delays in payment.
Yeah, generally, well, we have put on that a bit about the dichotomy of private health insurance, and the truth is that it cuts across. It's a systemic thing, and it's something that needs to be addressed seriously. HMOs, there's no doubt that majority of the time, many of them are not paying when they are supposed to pay. But we hope that that challenge can be overcome. It does not hinder service delivery at all. It doesn't.
Let me weigh in on that. Okay, so part of what we have seen in our experience supporting health insurance in Nigeria is the opinion of many of the key stakeholders. Of course, Dr. Ephraim is one of the providers. He is in a federal tertiary hospital. So we have interacted with providers in the private sector, those who are in the secondary and even those who are in primary healthcare settings. Now, so for a provider like Dr. Ephraim, or let me say like FMC Jabi, that probably will have over 50,000 enrollees. They wouldn't have any issues. They wouldn't even recognize any issues. But if you have a private sector that has providers less than 100, and then you would have to provide services to people with your own resources, and you are not being paid, it becomes an issue. Now, so the point here is, where are those delays? What are where are the weak, what is the weak link, or what are the weakest links? So again, in the analysis that we have done over the years with the LHIS, so we have found that the managed care system is a challenge. We did analysis of many countries in the whole world, and we find that it's actually only the United States that is running the managed care system. And again, it's a lot of issues, comes with a lot of inefficiencies in terms of even cost. And that's the reason we recommended, Dr. Kofi, you can correct me if I'm wrong, we recommended that in setting up of the decentralized health systems at the state level, that we encourage capacity building among the government agencies running the insurance to be able to take care of all the programs within the continuum of provision of essential services. And of course, we have found good experiences in states like Delta. We found experiences in states like Anambra, even Kano, and some other states where they are doing everything alone without the HMOs. Countries like Ghana, Rwanda, and the rest of them in Africa that are even doing very well in health insurance don't understand what the HMOs are doing in our system. And this is not to say, again, we need to get this out of context. I don't hate the HMOs, but again, this is scientifically what we have found in our reviews in supporting the health insurance system in Nigeria. That where the health insurance agencies at the state level are making the payments, there are no delays. Because they pay at any particular time in the period of time. Fabog, you can also correct me. And even though the problems in quality of care are still there, and that's where I agree with Dr. Nega, that the regulatory function of the health insurance systems needs to be strengthened so that they will be able to create not only choice, but they will also create competition among the providers. And then those who are receiving the services will have a choice as to where they will have to receive these services to be able to stimulate good practice within the system. Thank you.
All right, thank you, Dr. Francis. So there was a question, and it says, is there a need to have a regulator for NHIS or the health insurance ecosystem in Nigeria? I think in responding to this, we should also take into consideration the reforms that are going, the legal, because the NHIS, the law that set up NHIS is going through legislative process now. And I know that issues of regulation, or I don't want to say unbundling the regulatory function and then the management of the insurance system. So what sort of regulation do we need, or what areas or aspects of the regulation with respect to insurance that we need to strengthen? And also in terms of capacity, I'll come back to Dr. Farrow, just keep this in mind. What sort of capacities do you guys at the state level need to be able to properly manage insurance at that level, at the subnational level? So Dr. Nega, what is the government doing to strengthen the regulatory functions of NHIS? And also, Dr. Kofi, after Nega, you need to let us know what NHIS is doing in-house to improve regulation and the regulatory functions of NHIS.
Thank you very much. So, just a quick one. A few years ago, there was the bigger insurance one. So that right. So there was that confusion, and the law was supposed to go to the floor of the House to say that health insurance should be under and should be regulated. But we're able to argue that health insurance and the general insurance system are not the same. And so it will create some confusion and distraction. People say, look, you be on that. So, I mean, that's settled as part of making health insurance mandatory, okay? The roles and responsibility assigned to the National Health Insurance Agency or scheme, whichever you choose to call it, has also been clearly demarcated, and that's why the issue of having state health insurance, is coming on, such that they will be at the level of spearheading the purchase of services. So that's what we call the decentralization going on at that level, such that at the national level, they are only saddled with ensuring, monitoring and evaluating what these other levels of the health insurance system is doing. I believe Kofi will throw more light on that. So removing some of those purchasing function at the federal level from them, and then making sure that it happens just at the state level. At the national level, they will only be able to provide policy directions and framework for the state health insurance schemes to function. So it's still a gradual journey that is in progress. They are not yet there, but all of those discussions are all on the table ongoing. Thank you.
Yes, sir. You have a question?
Yes, okay, from the audience. Okay.
Thank you. My name is Nwoko. I have a question, and that's this. For me, I have been ready for market-driven economy, but considering the level of poverty in the country, and if you look at what
countries like the United Kingdom is doing, where you have a publicly funded health insurance scheme. Don't you think it's possible we start looking towards where we collect taxes and use it to fund a kind of universal health coverage? Because where we are going, I know we love what the US is doing, but are we able to guarantee health insurance to average Nigerians who can't even afford to spend millions a day?
So let me just.
Hello, can I say something in that regard?
Okay, Dr. Fabio, let's allow you, but Dr. Nick, I wanted to say something before you come in, please.
So let me just drop this before we come in. So, like I would always say, health insurance, universal health coverage, will naturally flow with the dynamics of the country. So over time, we have looked at our resources in as much as having mandatory health insurance is desirable as a country. We must also come to terms with the reality of funding a mandatory health insurance, from especially covering the vulnerable group. So there are lots of efforts ongoing. Most recently, you would have heard of the Pro-Health Tax, which the leadership of the Ministry of Health and Finance are spearheading. So, but the point now is, in as much as we talk about these taxes and all of that, look at our system. So it's not just about proposing these taxes. When we do propose them and they come into being, we don't collect these taxes. So also now have another tax of making sure that the tax comes to the health sector for financing health intervention. So there are lots of efforts, taxes and all other channels. Like most recently, as part of coming up with a sustainability plan, issues around having marginal oil blocks, exploring marginal oil blocks, also came to the fore, and that discussion is also ongoing. Very sensitive, very political, but we're looking at how to make sure that expanding our health insurance coverage also comes with additional fiscal things to make sure that it happens, and not just that, and it is also sustainable. Thanks.
All right, sorry guys, actually at the time I realized we've been here for almost 2 hours, so we just have 10 minutes to just wrap up. My last round of questions, I'm sorry we don't have as much time to discuss as much as we would like to, but I would want to go around from both Fabio, Kofi, who are online, like what are your last words? How can we improve one coverage or expand health insurance and make it more sustainable? I mean, obviously, what the question that I want to ask is actually going to help us. So we'll just go around, maybe for Dr. Neka and Dr. Francis, maybe like how do we improve the regulation and making health insurance better in terms of both the private and public sector? Then I'll come to Dr. Udu later. I mean, Dr. Ife. But Dr. Fabio, like, what can we do to improve health insurance at the state level? And then Dr. Kofi, our question would be, what is NHIS planning or trying to do to improve the health insurance ecosystem generally in Nigeria so that we achieve universal health coverage?
Okay, sir. Thank you so much for that question. It's just a rider from where Dr. Neka stopped, and I think health insurance, in my own opinion, should be tax financed rather than contributory as currently being structured. The contributory financing is largely dependent on ability to pay, which, in my own opinion, is largely inequitable. If you look at the model in the United Kingdom, it's tax finance, and this is no departure from the fact that you impose certain taxation on some goods, and then you create a larger pool to that regard. But in Germany, for instance, they practice solely social health insurance scheme, and the reason being that the population, the larger percentage of the population could afford going forward. But if we have to make sure no one is left behind, we have to move to that level of tax finance insurance rather than contributory. And I ask questions. I pay a third-party insurance for my vehicle registration. Of what importance is that to me? But if you talk about taxes, everybody pay taxes, whether you work in government or you don't work in government. The government has a way of taking taxes from you. And if we say it is an enormous tax bringing about these taxes, then it also goes to show that it is our inability to farm these taxes, as it were. So to improve health insurance in this country, we have to move from the contributory nature of financing it to a tax-based health financing, which will improve health insurance in Nigeria. That's my thing.
Thank you, Dr. Just if you can tell us in 1 minute, we want to wrap up by time. Hello, Dr. Kumi, are you there? Okay, maybe Dr. Francis, you can.
Okay, thank you very much. I think this has been a very interesting discussion. So moving forward, we have to do some reality check. As of today, we still have out-of-pocket expenditure in Nigeria that's over 73%. Ideally, the benchmark should be not more than 40%. So in all of these discussions and English that we're speaking, there are still over 68% of the population that are still falling into poverty due to access or inaccess to healthcare. So what do? We cannot run away from the fact that insurance in Nigeria still remains a good vehicle towards achieving risk protection for health for our people. And the NHIS has done its best and still continuing. Now we have the state health insurance agencies with the coming on board of Rivers State in June last year. All the 36 states have it. But as of today, about only 19 states are providing services through insurance, even though they are eroding. So there are all of these reality checks that we need to take into. So what do we do moving forward? And of course, let me also add that regardless of what people think about the informal sector, we also did an assessment of the informal sector with NHIS. Dr. Kusi is here. We find that the informal sector in Nigeria, against what people thought, over 80% of the people in the informal sector want insurance, but they have said that if they will need to access insurance, that the health insurance agencies will need to up their game. So how do we ensure that they up their game? I will just make like 4 or 5 suggestions. One, we need to ensure that we push health very high on the agenda of government. Dr. Neka had mentioned we are going into an election year. We need to ensure that every governor, every senator, everybody who is coming in as a president would not push health aside. Health must be one of the topmost priorities. But it's not just about saying it, it's ensuring that their actions match their vocal or oral commitment. We need to ensure that the legislators understand what we need in health and push it. And the legislative network for universal health coverage has proven that that is a very good way to go. Number 3, is it possible for us to employ new technology, innovative means of ensuring that we even cover the private sector? There are a number of iterations that are happening within the country using mobile health insurance. And again, this has proven to be useful in other countries. And the 4th one is how do we ensure that there is appropriate coordination so between the NHIS and the state health insurance agencies to ensure that the coverage that we have now that is, I would say, modest 12 million out of the 200 million Nigerians, that we increase that within the next 5 years. So comes to mind, health insurance under one roof needs to be implemented. And finally, we must strengthen the implementation of the basic healthcare provision fund. So to your question, Dr. Ndlu, Nigeria has a mix of sources, mix of health financing strategies, which is really what is recommended. as good practice. So there is a payment of premium, but again, let's not forget that the basic healthcare provision fund is tax-based. If you see where the consolidated revenue comes, it is taken from everything that the country gets, from taxes, from CIT, from all of those sources, and then that is where the 1% CRF is coming from. And that's exactly where the guys in Ministry of Finance will argue that if they are also going to earmark funding for health again, it will be double digit. So let me stop at this point, and I want to thank every one of you for participating.
It doesn't take only a few seconds, 30 seconds, please.
Okay, so I think Dr. Francis has really, laid that trend, but I'm not a politician. I don't dislike the politicians, but I like to tell them the truth. I mean, if politics must continue, health has to be top on the agenda. That is very critical, and it impacts on every facet of health. State governance, those people who are aspiring to take that work, they need to be made to take responsibility for the health of their people. And so, I mean, I'm using this opportunity to charge the media police. When those discussions will start happening, please articulate your questions to them. They need to be held responsible. Health has to be politically discussed and taken seriously. So for me, that's my final word.
Thank you, Dr. Omega. Dr. Ephraim, what are your final words coming from the provider's perspective?
My final words are these. We need to do a lot of enlightenment. Knowledge gap is a big factor across board. I say this with all due respect and sense of responsibility from regulator to the operators. Many people know that there's what is called NHIS guidelines. But if you confront them, they hardly know what it says. I have my facts on this, I say this from experience. So we need to look at that book from cover to cover to be able to administer as a regulator or as a provider or even the HMO. So we don't create unnecessary problems in this service delivery. We need to understand, even from the discourse that has gone on here, we need to understand the principles that underpin health insurance. We really need to, apart from the operationalization in the field. So that's one takeaway. I will invite everybody to go to the FMC Abuja website, fmcabuja.gov.ng, www.fmcabuja.gov.ng. You will find that FMC Abuja had a stakeholders summit on the 30th of September 2021. And there's a report on that summit which contains resolutions. Some of those resolutions have addressed the gaps and what needs to be done. And one of the major recommendations is what I have just talked about, information. We need to train ourselves. HMOs, I don't know how often you turn over your staff, but do you just engage them, give them the desk, give them the computer to start working? You need to take them through training so that they understand what exactly they are doing, so that if we engage in a conversation, we can understand ourselves. And you don't have to create problems of writing petitions and all that without having the facts, without going through the right channels, without making the right contacts. That will help a lot in fine-tuning the system. Thank you very much.
Right, thank you, Dr. All right, thank you, Dr. Ephraim, for wrapping. And before I come on next year, first of all, I just really want to thank all the panelists. I think we should give them a round of applause. And also, we want to thank the audience, both those online, virtually, and those physical. And I'm sorry we didn't have as much time to move the microphone around, but we thank you for all the feedback. And one point I want to make is that we will synthesize this conversation because there are different teams and all. So the next year team will synthesize, and then we'll share the output from this dialogue with everyone that registered and those who also came there physically. So I just wanted to let you know that. And then there are one or two people who asked about the NHIS 10-year strategic plan. So we will get a copy and also share with those who registered for this dialogue. Just wanted to make that point. So we will get an e-copy from NHIS and it can be attached or sent to those who requested for it. So I want to thank everyone. And just before we wrap up for today, I want to invite Dr. Du of next year to really help us wrap up the welcome.
Thank you, everyone. This is really great. I can't even believe that this is the first of this discourse. So we know we're going to have a series of this discourse monthly, and we'll ask the audience, both those who will be here physical and those who will be virtually, to watch out for the details of how these programs will keep unfolding. Felix, you've done the thank you to our panelists, and I wish on behalf of next year to say thank you so much for honoring us. I think this has really given Nigerians food for thought. I know a lot of people will be bombarding our email with what and all that. But it's good we are. If we don't continue to engage, at least where evidence is the base, then we'll continue to wallow in, I won't use the word idiocy, but the world is driven by knowledge, and I think that is the essence of this work. On behalf of Nestia, which is a multi-competency public sector advisory firm, we want to say thank you. For those of you who know about us, our business covers the power sector, public sector advisory, which is part of what we're doing today, and security, peace, and development, which we are currently doing a lot. I want to thank everyone, especially the audience who are here, and those who, you can imagine we have over close to 200 people online. Wow, which is good. And the questions are keep coming. So we want to thank everybody. And two things came out here and we are very key. One is that I noted this already, that universal health coverage is a political decision states need to take in order to provide basic health for their citizens. So it doesn't matter how you want to do it, all your citizens want basic health. Sure. Another key point that came out is built on partnership between state and non-state. I think this is key. Sure. So Chidima will be Emeka Okafor and those who have worked to put all these things together. Thank you so much. And I know everybody will watch out for the policy brief that will be coming out from there. We're going to, as much as possible, put everything and make sure that people get the brief and then be able to read through and then make decisions. Once again, thank you. And again, on behalf of Patrick Okibo, who was supposed to do the welcoming, I want to apologize. He was supposed to be here, but they left yesterday